Two short items of business to go through before we get to our main work for the morning. Can I have any apologies for absence, please?
Thank you. We've received apologies for absence for Assembly Member Twarkos.
Thank you. Can I ask members to note the list of officers set out on item number 2 of the agenda, and also ask members for interest to declare? Yeah, noted? Yep. Thank you. Can we note the outstanding actions arising from our previous meetings?
Noted.
Thank you. That brings us to today's main item, discussion on the Mayor's health agenda. Can I welcome Dr. Tom Coffey, Senior Advisor to the Mayor on Health Policy, and also Professor Yvonne Doyle, Statutory Health Advisor to the Mayor and London Regional Director for Public Health England. Also, Dr. Coffey, thank you very much for sending your slides in. Presentation. I'm sure the members have had the opportunity of looking at that, and we'll take that on board on our questions. So thank you very much for sending those in advance. I'll just start off with we'll start for 10. Okay. Perhaps I'll start with Yvonne, with you. How much of the priority is health and well-being to this mayor?
Well, the Mayor's Manifesto, Chair, expressed a number of ambitions for health, particularly around children and mental health, and communities that are suffering disadvantage, and that expressed in terms of HIV and TB. So we had a good template as officers to work on that. What we have done with the agreement of the Mayor is to translate that into programmes that people would recognise as offering services or improving the trends. And that's where we've been for the last 2 years. The Inequalities consultation was the expression of that manifesto through the lens of disadvantage, which is, and we, as you know, we've finished that consultation. Very happy to give you an update there, but we anticipate a good strategy as a result of that.
Okay. Thank you. The other thing, of course, is Professor Doyle, this mayor has appointed 2 health advisors. One, you're the Statutory Health Advisor, and Dr. Coffey, you're the Health Policy Advisor. How do your 2 roles interrelate, and how do they and how are they different, right? And what role do you play in the health team?
Would you like me to answer that first, Chair? So I see our roles as complementary. My employer is Public Health England. I'm not an employee of the GLA. So in a sense, I also am offering in a service to the GLA. And I will afford the amount of time that's necessary, and that's very flexible. But broadly speaking, it's about a day a week. We also fund a head of health through Public Health England, who's Dr. Vicky Hobart, who is an ex-director of Public Health actually very recently. So we're fortunate to have that, and then the Mayor's team wraps around that. So on the prevention and the public health side and the interface with the NHS insofar as it deals with prevention, that's an area I provide input, practical service and advice. Tom's role is with the NHS. I'm not of the NHS anymore, and I don't know what it does day to day anymore. So this is very helpful, having both a practicing clinician but also someone who works in the NHS alongside.
So what I bring is issues regarding policy and experience with the NHS itself. So I'm a GP of 24 years. I work 6 sessions a week. I work in A&E tomorrow morning at Charing Cross. I've done that for 22 years. I have spent the last probably 20 years doing lots of health policy stuff. So I was London Associate Medical Director for 5 years. I'm the present Urgent Care Director for London for the last 4 years. I was Executive Chair of Wandsworth PCT. So my background is very much on how the health service works, how health policy can often be converted into implementation, and also what I bring, I guess, is the day-to-day frontline experience of working within a hospital and with a general practice. The 2 main areas, I suppose, that Londoners interact with the health service.
Thank you both for that, and I think my colleague will take the question further.
Oh, okay, thank you. Morning. Tom, to start with, I was very impressed with the amount of other roles you've got. They go on and on and on. You seem to be doing so much. But, I mean, bearing in mind you do so many other things, how much time do you devote to mayoral work?
So I reckon I spend a half day a week. Sometimes more, sometimes less. And that's the commitment I gave to Sadiq when he asked me to take on this role, because because I felt that to try to reduce my clinical face-to-face commitment work would undermine my ability to give that kind of advice and to be a credible clinician. So I'd say, sometimes I spend a day a week, sometimes, half a day. So yesterday I gave a talk on behalf of the Mayor to the Urgent Care Collaborative for London. This morning I'm doing this with yourself, but next week I might only do one session, so it varies like that. I do have lots of roles. As a GP, we learn to multitask, and I make sure I compartmentalise my work accordingly. But I reckon about, on average, just over half a day a week, I'd say.
Okay, so between the two of you, it's 1.5 days around a week. Okay, so Tom, you've been in role 2 years now. Yeah?
I started in September 2016.
Okay, well, out of that time, what have you done or achieved that is the best thing in your mind?
Okay, so I'm going to just talk about a thing which is perhaps the most imminent, kind of for us, and I suppose it's around kind of mental health. And so Sadiq put in his manifesto that he wanted to have a strong focus on mental health. And so there were 2 or 3 areas in that which I think we've worked on recently. The first one is about mental health first aid. So I reckon that mental health, unfortunately, is not improving in London. And we're trying to make sure, how can Sadiq, in his role as mayor, kind of give a leadership role in mental health? So one of the areas we've looked at is talking about mental health first aid. And so what we know, most buildings, most offices, most factories will have, quite a few people who are first aid trained in physical illness. But when you look at it, most people at work who have a crisis, it's often linked to mental health issues. And mental health first aid training deals and helps you deal with how to handle a mental health crisis. So I said to Sadiq, if we can start getting this embedded throughout London, getting more and more people being trained in mental health first aid, I think that will make a massive difference. And I think the way we can start is by you doing it yourself. So in August last year, him and his deputy mayors did their mental health first aid training. And then we're rolling that out also throughout some of the GLA and other kind of associated bodies, TfL, etc. But also trying to make sure that in his leadership role, he convinces much of London to see this as an important part. Linked to that, I'm going to launch this in May, is the idea of a dementia-friendly city. And so one thing which I met with the Alzheimer's Disease Society, and they laid out a path towards becoming a dementia-friendly city, and very clearly saying that in London, more and more people are developing dementia as we get older. Secondly, every Londoner probably is touched by dementia, either a family relative or you in your care role. And we want to make sure that London is as dementia-friendly as possible, and not just for the benefit of the patients, but also for the benefit of London. So if you've got a city which is seen as dementia-friendly, more people with dementia will visit as tourists. Businesses who are dementia-friendly will get better business. And so the idea now we're trying to launch on 21st of May is London becoming a dementia-friendly city. The Alzheimer's Disease Society have supported this, and it involves people becoming what's called dementia friends. And what you've got to do is literally about a 10-minute video, and it really just goes through is, how do you recognise a person with dementia? What can you do to help that patient's life, be it on the bus, be it in your shop, be it when you're in the tourist industry? So if we can get thousands of Londoners becoming dementia friends, making London a dementia-friendly city, we think that will help London. And Sadiq has agreed to promote this. We took it to London Health Board at our last meeting, when our local authority partners, our NHS partners agreed with this, and we're now launching Dementia-Friendly London on the 21st of May. So I think those 2 things, I'm just thinking, that we've done recently, is giving a reality to what it is about leading for mental health.
Okay, fine. So that's 2 examples, which is interesting. Going back to your other roles, do you have any conflicts between the various roles you've got?
I make sure I kind of always declare. So therefore, I declare my interest in all my roles. as you might be aware, this is not a paid role that I do.
No, I accept that.
Yeah, and so the role within as a GP, I make sure that my partners are aware that I am also an advisor to the Mayor. My work within the CCG, and I'm an advisor. I work as a clinical lead in Wandsworth CCG. Equally, I make sure that I advise, the board and organisation of my role here. But I've yet to come across any conflicts, and I'm very clear and explicit with all my colleagues of the role I play to and for Sadiq.
Okay, and I'm assuming by what you said earlier, Yvonne, that therefore Tom can provide things that you can't provide.
Absolutely, Deputy Hall. The roles complement, and however, there is quite a lot of interaction, particularly on areas like mental health, where we really look at the whole pathway. So I always call it a kind of interdigitation about this stuff that we're trying to do upstream on prevention and services there, and how they might actually play out in clinical practice. So at that interface, we do some very close work together. But mostly, we do not duplicate. There isn't enough time.
Well, it certainly doesn't need 1.5 days for such an important thing. I mean, obviously, Sadiq has made a lot of comments about putting health into everything and into different strategies, etc. So who is actually providing the day-to-day leadership on that? Because if even transport strategies and all of these different strategies, well, on 1.5 days, which one of you is dipping into all these different strategies?
So maybe we can both answer therefore. So there's obviously a whole health team. So myself and Yvonne, have an advisory role. We've got head of health, Vicky Hobart, started recently, who is full-time and gives that kind of very much day-to-day kind of input. Also, Yvonne's team has seconded people into some of the departments to actually give, that day-to-day advice. Transport is a classic example, which I think Yvonne might want to give as a working example.
Yeah, thanks, Tom. So, from the word go, I aimed to get health into the other areas of the GLA. And we started with transport, and this has been a mature relationship now. So I funded a consultant in public health to work in the Transport for London team, and that post is now secured and has built on. And that has been the kind of way the thinking has changed into the Healthy High Streets approach by TfL. Obviously it's not the only thing that can be done. There's a lot on air quality, but it has really changed the thinking from within. Now, the next area we aimed for was working with the deputy mayors on the London plan, because this is crucial really to the environment, and it particularly is important for local government. And we have a part-time consultant in public health working with us on the London plan. That person is also based in Barking and Dagenham, so has that kind of reality as well about how that would play out in terms of planning and healthy environments, healthy schools and so on. We're now working on how we could work more deeply with the Met, because one of the leading edges of concern to me is crime and the impact that crime is having on the population, but also why this is happening and what's happening with these young people earlier on. So can we work more closely with MOPAC? So that will be a new front for us really. So we'll work our way around in terms of the investment. In terms of leadership, I now, certainly since this mayor has been in post, have made my way through all the deputy mayors as well to discuss our joint agendas. Where this is played out particularly is in the Health Inequalities consultation, so that we cross-reference the overlap between environment and health, between transport, between leisure and culture, the night economy and so on. So, given I have more time, and a lot of this is upstream, it's preventive work, I take the majority of the leadership for that. And this week I will be meeting the deputy mayors again to make sure that we're aligned in where all our strategies are going.
I'm a little concerned because it is a very important issue, and it's really it is the leadership of it, given that we're looking at 1.5 days. I mean, the mayor's sought to put in place a night czar and all of this sort of thing. Is he looking to put in place a health czar or a deputy mayor for health, or what? Because if we want to go to, I mean, I don't know if we've had an answer to this extremely good letter that Angela sent in November, but last time I asked we hadn't. There were specific things that we wanted answers to from this letter. You've seen the letter, have you?
Yes, yes.
Who would be responsible for us to go to and say, why haven't we had answers to this? Because we are interested in health. We want to make sure it's being done properly. We want to make sure that there's leadership there. And on 1.5 days a week, I'm certainly concerned that isn't enough time for you to do all the commendable things that you want to do. And if you're not answering letters that we sent in November that were asking for specifics with time scales, you know.
So I think the letters would normally go to the health team, within the GLA, and so what they always will do, letters from yourselves, will be kind of to make sure that that input from myself and Yvonne is given to any response that is required. Letters will go directly to Sadiq, and I will discuss with Sadiq. I have regular meetings with Sadiq to discuss issues regarding health throughout the whole part of the mayor's work. And so I would normally expect, Uncle will often write to Sadiq, and then that will be passed to us and the health team. Equally, I think one can also write to the head of health, Amanda Coyle, who will also kind of take action according to what is required in the letters. So I think there is a system in place to make sure we receive any letters that you send, and also from myself or Yvonne, whoever is appropriate, to give the appropriate advice to the response that is required.
In all the other areas, there is somebody specific to go to. Do you not feel that 1.5 days for you to be in charge, as it were, of health is sufficient? Or do you think there will be a health czar or a deputy mayor for health or whatever? Or do you think that you can manage on 1.5 days?
I mean, so I feel at the moment that we have really pushed a health agenda, for Sadiq's teams. And if you look at the work Sadiq is doing, is making sure that all his strategies have a strong health element in it regarding environment, housing, transport planning. I think that the work he's doing on mental health, the health inequalities. So I think most of the work that he's doing, I am quite confident is covering a lot of the health areas that are required. Undoubtedly, everyone always wants more. I can understand that. Saying, how can we get an even wider team? A greater level of support. I think at the moment, in the work that we're doing, we feel we're covering the areas that are required. The question, am I aware that Sadiq is considering recruiting to a health czar? I'm not aware of that. But it might be a direct question for him.
I just find it very strange that if it is so important to him, as he keeps stressing it is, that we've got people leading this, you two, very competently, I'm sure, but only on 1.5 days a week. And both of you have got very many other commitments, which are commendable commitments, but nevertheless, you must, both of you, be pulled in every single direction. And one wonders how much time you can give to this when Sadiq thinks or says he believes it to be so impossible.
The way I look at it sitting here is that people watching this, the organisations, the individuals, they want leadership on health issues. And I can see your role very clearly, Professor Doyle, that you are getting public health and prevention into all streams of work within the Assembly, and I think that's commendable, and I can see that happening. What I don't see is where does any organisation, any pressure group, any people who are concerned, who do they go to, right? And how does the mayor interpret leadership? One interpretation of leadership is that he has a statutory duty for inequalities, right, and producing this strategy. But it's a wider role in leadership, okay? And I just want to know, how does he interpret his role as in leadership? Is it just to comply with those minimal requirements as laid down by statute, or does he see a wider role for himself in leadership in health issues? And that's a question which not only comes to my mind, but it comes to the mind of Londoners and organisations that approach me.
So my initial thoughts, and it's all very much a double act. So
and that may be part of the dilemma.
Yeah. So and I think sometimes when you want certain skills which aren't in one person, that's why I think people try to bring two people to do a certain role, and so Sadiq's got a statutory responsibility regarding the Health Inequalities Strategy, but he doesn't commission the health service. He doesn't have spending powers significantly over health. So therefore the leadership that he has to express is either by doing personal leadership, which he did with the mental health first aid training, whereby he will use organisational structures like the London Health Board, or how he uses his transport strategy to push forward the Healthy London agenda. Or he uses powers to convene. So therefore, when we're launching the Dementia Friendly City on the 21st of May, that's his ability to convene. So leadership will come in many ways. And so Sadiq makes sure that he is aware of his limitations in health, but also his power to be listened to and to convene. So I think he tries to use all those different ways of leadership to express that personal commitment he's given to health. And myself and Yvonne work together to provide very much a wide array of health experience, both face-to-face and policy, and also to cover as wide an array of the health service as possible, from the preventative agenda right through to the health service agenda. So I will often, on behalf of Sadiq, be the person who will go and talk to the NHS providers, the hospitals. I will talk perhaps to the commissioners, in next Wednesday. Sadiq has been very clear that he wants to see a strong relationship between the City Hall and CCGs, clinical commissioning groups. So over the last few months, we've persuaded the CCG chairs of London to have their meetings here every 3 months. Sadiq has attended those meetings. I'm going to the meeting on Wednesday to represent Sadiq, to have a wide discussion with those CCG chairs who are the clinical leaders of London, who are coming to City Hall, who see that Sadiq's role in health has been so impressive to them that they feel they wish to be aligned with his work. So I feel that leadership has been expressed, and in fact it has importantly been recognised by the rest of the health service, whereby people are coming to him from the health system to say, can we work with you? And I think the CCG chairs meetings occurring here now is probably a hard evidence of that fact.
Do you think CCG chairs are delivering the agenda of in London, which is what Londoners want?
So
do you personally think the CCGs have been a good thing for London, and as the engagement of CCGs with the grassroots GPs, with the grassroots public, is it good? Do you think they're democratically elected bodies?
Right, now you're asking a question.
No, you seem to be giving the impression that CCGs are the best thing since sliced bread, right?
No. So what I'm saying is the CCGs, the clinical commissioning groups, have been set up by the government to commission services on behalf of Londoners. They've been given a budget for about 80% of the NHS budget. Therefore, they are key people, CCGs are, in how we design and organise London's health services. Therefore, I think it's very important that Sadiq, in his role as mayor and wishing to be a leader within the health field, has a strong relationship with them. The CCG London chair is Mark Rowland, the GP. So he sits on the London Health Board. He meets with his CCG colleagues regularly. It is vitally important that we, within the mayor's team, have a close working relationship with them, and they have expressed the desire to work closely with us. Whether in fact CCGs are the best things since sliced bread, I don't really want to get into that, but what I do know is they've got a very large health budget. They influence the spend on Londoners. Therefore, I think it's vitally important that Sadiq and I are close to how they work.
These are the same CCGs that produced the STP plan for London, which have been roundly condemned, right, by the King's Fund report commissioned by the mayor.
Yeah. These
are the same CGs, right, who have got it wrong looking at the provision of healthcare in London, which the mayor commissioned, and have said that we need to make sure that those things aren't delivered without 5 assurances, 6 assurances.
Yeah, but I still think it's also vitally important that the mayor, in a health leadership role, has a close working relationship with the CCG chairs. Because I've said they control the health service budget. And I think to say that, I wish to have nothing to do with them.
I didn't say that.
Right? So, I'm just being rhetorical here. I think will be ill-advised. And so I actually think that what the CCGs have done by wishing to move towards London is a reflection on the role they see Sadiq as mayor playing in leadership within health.
Do you think you being a member of a CCG board has any conflict of interest in you giving that advice?
I'm not a member of the CCG board.
Did you say you're a clinical lead in one of these CCGs?
I'm a clinical advisor to the CCG.
Okay, you're clinical advisor to the CCG. Sorry.
Because obviously I think that would be a conflict. I wouldn't do that.
Yeah. Okay, thank you. Andrew?
CCGs have been quite innovative, though, haven't they, in the stuff they've been trying, especially with things like diabetes care.
Some CCGs, in fact, it's always the case is that every organisation in CCGs, some are doing fantastic, some are struggling, but everyone's doing something quite unique and innovative. I know my local CCG, they've worked fantastic with Citizens Advice Bureau, bringing the Citizens Advice Bureau advice into every single practice. And that has been transformative for me as a GP.
And they didn't have to wait around to be told to do it by somebody in the centre.
Correct. They're an autonomous body.
Very good, thank you. Professor Doyle, what progress has been made on developing the delivery plan for the and indicators for the Health Inequalities Strategy?
Yes, Deputy. So that is work in hand. It's working at the moment because the strategy is due for publication in June. And obviously with the background of Public Health England, we have access to a range of data that can certainly indicate on population indicators. I distinguish here between the population and what we're trying to show there, and two people in London, and the actual delivery of the promises in the strategy. Given that we're just at the conclusion of what people said and particularly what some of the stakeholders have pledged, I think that will give us a good indication of where the mayor's role fits in this, which we have a firm view about, but we just need to take account of what people have asked for as well. And then what others have said they would do. Now that will form what the mayor will do will form the basis of the delivery plan, and there will be KPIs on that, and that's being worked on, for sure. On the population indicators, we took a fairly early view on that. The indicator that we're still very focused on is healthy life expectancy, because that really does indicate the inequality in London, and there are wide variations in that, and we can get quite low, close to the ground on how that varies. So I think we're looking at an overarching indicator, population inequality relating to health, and then a range of population measures that show us what progress we're making on anything we are doing in programmes around the various promises in the strategy. So for instance, we would be looking at what would be the right indicators for the early years, and we have a whole range of them. There will be no problem getting indicators that are valid and are credible, and indeed are already perhaps in the public domain, but would be focused more on inequalities now.
So we'll see a delivery plan in June.
We will.
And the KPIs will be in there.
Yes.
And also the indicators.
The population profile indicators as well.
Right. Have any substantive changes been made to the inequality strategy as a result of the consultation exercise?
No, Deputy, not fundamental that we'd have to reconsult, but obviously we've heard some of the things that people have said, and indeed I discussed with this Assembly back in September, and some of that came back in responses as well, around the need to be sure we are actually focusing not just on universal improvements, but on focusing on where that will benefit those who are most vulnerable first. So we will definitely be making sure we account for how we're going to do that. So there's not the actual 5 areas that are committed to are the areas where we are absolutely sure that London differs in its, what it needs and its inequalities. We need to make sure that we're indicating how we address the inequalities.
But are we going to see much of a change between the draft inequality strategy and the final inequality strategy?
Not in
terms of the consultation?
No, not in terms of things you would recognise, but it will be shorter, it'll be sharper, and it will have these indicators. So in that I would expect you to recognise it, but also it will have taken account of what people asked us to be more focused about.
You received a number of recommendations from the committee, this committee, on sight loss and mental health.
Yes.
How have they been incorporated into the final strategy?
Yes, so what we're doing at the moment, and by the way, I don't think we did answer the question about the letter. We have responded to the letter, just acknowledging that. But that letter actually will be fully responded to. It will be part of the response of us to the consultation. So I do apologise if you feel you haven't had that yet, but you will, and we are aware of it. But in the letter, I'm aware of those elements. Now, what we've done is we've gone through that and indeed all the responses and laid out what people have said and what we feel we ought to do. And there is a chart on that, and in there is eye health and mental health. On eye health, again, the services for eye health, we are not, the inequality strategy will not deal directly with that. However, what I have been looking into is how we can actually address eye health in terms of the life course, in terms of the children's signposting where children have eye health problems, and particularly in the part around old age and ageing as part of the life cycle approach we will take in the strategy. So that's important. I've also looked at what we're already doing and how we can make sure that that is fully understood and we get the best benefits. So we have a very good diabetic eye screening program. It covers at any time, it's meant to cover about 500,000 of the population who may be at risk. We have a diabetes prevention program which also looks at how we can curtail the damage, a lot of which happens to the eyes in diabetes. I've also looked into how the history of how we've dealt with macular degeneration. So we are looking at what it is appropriate for this strategy to address and how we can make sure that we account for augmenting the good programs we do.
But you're not actually going to have, you are going to have a section, surely, on... We'll
have a response about eye health. But I must say, we won't have an eye health strategy.
Okay. But it will... But eye health, sorry,
yeah.
But there will be a section in the strategy addressing eye health.
Yes, we will have a response on what people have said about eye health.
Oh, okay.
Yeah.
Okay. I mean, we'll look forward to seeing that.
Yes.
Obviously, we've made recommendations where we thought action needed to be taken.
Indeed.
And we would want to see that reflected in the strategy.
Yes.
Dr. Coffey, what role have you played in the development of the inequality strategy?
Okay, so I've been in discussions with Yvonne. Obviously, this is Yvonne's lead area. The role that I've played very much in discussions with Sadiq. So to say, what kind of strategy do we want? Do we want one which perhaps is a wider scattergun approach, or one which has got, some focus? And also about what should be our 5 main areas, and that they're very clear, I think, in a strategy. I've also been taking part in how do we make the strategy work and be delivered. So we're very conscious that we develop a strategy, it's got an action plan, there are certain things that the Mayor will commit to do, but the vast majority of the things which need to be done to address health inequalities are done by other partners, be it health, business or local authorities. So one of the areas which I worked on is working with the local authorities' health and wellbeing board chairs, because they're the ones who probably, in each local authority, have got a key role in addressing prevention and health inequality in their borough. So myself and Yvonne went to their main conference to try to persuade them. Can you, in some way, use your health and wellbeing board work, and you have an action plan each year to make sure it's taking into account what comes out of the Mayor's health and equality strategy. So therefore we've got a vehicle in 31 boroughs of saying the health and wellbeing boards will take on some of the recommendations in the health and wellbeing in Health Inequalities Strategy. Also, having met with some local authority leaders, there are significant financial pressures in the local authority area. And I think what they said they would find useful is for us to prepare a menu of opportunities that they could use which could address some of the issues regarding health inequality, which they can implement quite easily, and which they then can implement as part of their health and wellbeing strategy. So trying to kind of turn a document from a consultation strategy into an action plan, into how we deliver it borough by borough throughout London. So that's the kind of role that I've played, and we'll probably go back, I would imagine, to the Health and Wellbeing Board chairs after it's fully published to take that work further forward.
Could you let me know, I mean, bearing in mind it's an inequality strategy, the work that you've taken to try and get to hard-to-reach groups and communities?
Okay. So the consultation process has been very aware that we need to make sure that and I'm going to ask Yvonne to give the details of the plan, is that, I'm very aware that when I attend certain meetings when we're consulting, you can get people who tend to not necessarily represent their community, be it from my own kind of GP practice, when we try to get patients involved in a certain cohort of group. So Yvonne and her team have made sure, how can we make sure that we consult with people who represent London and not just represent, a certain cohort of London who tend to be more familiar with responding to consultation processes, more familiar with email and consultation documentation. So that there has been a very targeted approach.
Yeah, so Deputy, what we have done is just to give you an idea of the scale of this and then to answer the specific question, we've had over 2,000 public responses. The YouGov have polled over 1,000 members of the public on a representative sample, and we've had 221 stakeholders respond. The people that we wrote to through the GLA included a large category of groups that represent your statement of hard-to-reach groups, so the Gypsy and Roma community, disabilities, mental health, young people, black and ethnic minorities. And then there have been, during the process of the consultation, a number of seminars and meetings and consultation meetings with various of those groups, the details of which we can provide if you so wish. But they were specifically aimed at groups who we would wish to consult with who might not have responded. So we are confident in the responses we've had that we have actually covered a very broad range.
So I understand, you often have to say things twice to me before it's accepted. So you employed people to specifically address particular communities or
yes,
I mean to poll particular communities. Is that
yes. So the poll
was there like a list of groups, or was it?
Yes, there is a list of stakeholders which particularly includes groups who would be appropriate to inequalities, and there's a large number of them. The 221 includes that, but a good proportion of that would be groups who you would wish to consult with on inequalities. They cover a range. It also includes the NHS.
Are you able to give us the list of the groups you've consulted?
Yes, absolutely.
It'd be very helpful.
Yep, not a problem.
I mean, because there are very difficult to reach groups. There's, there's rough sleepers, sex workers, the trans community, those people without a GP. I mean, half the Lithuanian community in London, rather than going to a GP, gets on a plane to Vilnius when they're ill, and so. These are all extremely hard people to immediately contact by traditional polling measures. So I'd very much like to see that list of how we've engaged with those groups. I think I'm. Thank you.
You'll do the next question, also.
Oh, of course, I am too. Yes, absolutely. What new powers, perhaps to both of you, if I may, so whoever wants to go first, what new powers and responsibilities have passed to the Mayor and the GLA as a result of the Memorandum of Understanding on Health Devolution?
So again, we'll probably kind of give a kind of a joint answer. So the Memorandum of Understanding for Devolution sets out very much the framework for the approach that devolution will take in London. So it's not kind of a done deal. That's what you've got now, and that's what you've got forever. So so therefore, as we in London show we can kind of implement and deliver devolution, so I think the powers will kind of move forward. So the way that we've structured the governance around devolution, so there's a Health and Care Strategic Partnership Board, which is the operational kind of group which kind of sees how devolution is working, and the London Health Board is the board which kind of the SPB reports into. Sadiq is chair of the London Health Board, and so the present way we've operated over the last few meetings since we've had devolution is that Sadiq, as chair of the LHB, has had a discussion with the wider health community to say what are the priorities that are in the scope of the MOU, which we want to see implemented in the first stages of devolution. And him as chair, he has that role in coordinating that. That's gone back to the SPB for them to devise a work plan, to say what is the initial work plan over the first 12 to 24 months for us to implement devolution. And that's coming back to our next LHB, which Sadiq chairs, to get that work plan approved. So that gives you the kind of governance and the role Sadiq has within that process. The areas which devolution covers, which give very different levels of devolved power, are, first of all, NHS transformation funding. So previously, that pot of money was very much controlled by NHS England. That's now been devolved down to the NHS London area. So therefore, that pot of money, which is mainly committed, I have to say, for 18-19, but more uncommitted monies will be available in future years. That's come down to London for us to control how that's spent. So the money's been devolved to the NHS in London, but the strategic priorities and the work plan around it is signed off by the London Health Board, of which Sadiq chairs. The other areas are estates, commissioning, regulation, workforce and prevention. Each of those kind of 6 areas have a level of devolved power which may increase over time. In estates is one which is very...
when you say a level of devolved power, what does that mean?
Okay, so let's say at the moment for transformation funding has been allocated to London. So there are other pots of money which may in future also be devolved to London. So the NHS has money which is allocated to our hospitals and to general practice, and there are other pots of money which may be devolved over time. If I go for estates, and try to give you some examples for estates. So at the moment, the London has got a new London Estates Board, which tries to bring together the NHS, GLA, to see how can we oversee how we use the NHS estate in London. The devolved powers cover areas whereby...
Can I just clear that London Estates Board, that has executive power, does it? To make changes?
So it's got...
Does it make recommendations?
So it's got powers to make recommendations. Right. And again, I mean, the government quite rightly is going to make sure that as the process evolves over time, so therefore the powers that will be given to it will increase. One of the key areas, if I mention, so the ability of just working together just means the planning process might be a bit quicker. But on practical areas, when an organisation sells some NHS land, the receipts are gained, and prior to devolution, those receipts would usually go back to the Treasury. For the Treasury to kind of make sure the plan that we would put forward to use those receipts would have to require Treasury approval. That process is now being devolved to London. So therefore, in situations whereby the NHS can sell some property, and then the receipts that are gained from that property and how those receipts are used in the future is now devolved, to London. So therefore,
London controlled by
but really by the NHS in London, using the London Estates Board, which allows the GLA to have an input into that process.
Okay.
So therefore, it's devolution not to the mayor, it's devolution to London.
But really what I'm trying to get at this question is the actual executive power that the mayor will have. We know the mayor has a very important role in terms of convening people, standing in the bully pulpit, telling everybody what London wants and all the rest of it. We know that. Yeah. And the mayor sits, and all his representatives sit on a number of consulting boards. What we're trying to find out is about what executive power is going to be handed down to the GLA. Yeah. And you see well, that's really where we're heading.
Yeah. And I said, and what I'm trying to describe, whereby the process of devolution hasn't handed executive power to the mayor, it's handed power to London, and the GLA are part of that partnership approach.
London means to London, NHS London?
Well, it depends. So therefore, for the transformation funding, yes to NHS London.
Okay. Right. So, and the Estates Board, is that part of NHS London?
It actually sits in the GLA.
Sits in the GLA.
Yeah, and therefore the GLA support the board, but the receipts which are gained by the sale of the land, the discussion about how they're used, are at the London Estates Board, but the executive power there rests with the NHS in London. So I think very clearly what I'm trying to say is that the devolution hasn't been given executive power to the mayor, it's been devolved powers to London. Do you want to talk about the prevention area?
Yeah, so I think what we're describing here, and it is very difficult to explain this in public, so I understand why we sound like it's difficult to explain. It is. It's a partnership arrangement, Chair. So in prevention, we've deliberately called the Prevention Board the Prevention Partnership Board, and we have permissions as part of the memorandum to explore doing certain things, but not necessarily only by the mayor. So quite a lot of the exploration will be through willing local government partners who wish to try certain things to happen, for instance, around the high street. But those actions are not always within the unique gift of, say, the borough. They may need the support of the London Plan or the support around Transport for London, around advertising. It depends on what they're trying to do. The permission is there in the MOU to enable the appropriate partner to take action to accelerate something we want to achieve. And for me, the only way I can explain this clearly is to say, what is the outcome we're trying to do here? For whom? What population group benefit? And in the prevention MOU, the groups that will benefit if we got this acceleration right would be people, but particularly children, who are at risk of an environment that promotes excess weight. People at work who are struggling to stay in work, because part of the permission is to work with DWP on a better deal for people with mental health problems at work. And children particularly who are at risk of illegal tobacco, because we have permission to explore with the Customs and Borders Agency and HMRC about how we could explore an illegal tobacco team to stop this, basically. So we have to work with the Met, but with the boroughs as well.
Well, just to come in, supposing a borough is stopping the commissioning of the smoking cessation policy in their borough.
Yes.
What does your department do about it?
Well, that's not...
And what levers do you have to influence that? Because I've had some representations made to some boroughs are stopping the smoking cessation programmes.
Yes. And I'm aware there is a consultation at the moment in Ealing about this. So quite a lot, but this is done really in the discussions behind the scene. It's not a devolution discussion, and actually illegal tobacco teams will not deal with that element. They'll deal with the upstream of stopping these illegal cigarettes appearing, of which about, between 12 and 20% of the tobacco that's consumed in London is illegal, and it hits the inequalities streets more than anywhere else. On smoking cessation, local authorities have the freedom to invest within a ring-fenced grant how they see that money meeting the need of their population. That's not something that anyone interferes with, unless it appears that there is a service that will be completely bereft. Now, smoking cessation is one of a long list of public health interventions that is not mandated, but is certainly within the list of interventions that it is right to spend money on. There are alternative ways of providing smoking cessation and support to people who want to quit. So it doesn't always have to come through clinics, but that's the important element of any consultation, is what is the kind of mitigation for the removal of that particular service or the recommissioning. I mean, there's lots of it going on around London. My role is a Public Health England role, which is that our Chief Executive is accountable to Parliament for the Public Health Grant, and therefore we will explore very carefully with every borough where that is appropriate where that money has gone, if there's any reason to believe that it causes concern. Otherwise, we don't interfere. But it's not a performance management, but it is a legitimate role to inquire, raise a valid query as to whether the grant is being used appropriately. That would be not a GLA role, but it is one of my roles.
Thank you.
Will the Mayor be, I mean, we've kind of established, and I don't want to put words in your mouth, we've kind of established that despite these changes, these devolution changes, that there are currently no extra additional executive powers for the Mayor have been confirmed.
In the present situation.
Will the Mayor be seeking further powers, further additional powers as a result of this memorandum?
Regarding devolution?
Yes.
I think that there are no clear plans at the moment to say that Sadiq wants powers over, and I'm going to choose an area, let's say estates, to say, I want to decide how the NHS spends its kind of capital receipts. I think, what we want to do is to have probably good, clear decision-making structures which allow the GLA and Sadiq to say, when there's surplus NHS land which isn't going to be used for the NHS, can we have in a GLA the first call on the use of that land to build homes for Londoners? So that, I think it'll be in areas like that where he'll be wishing to have more power, but there are no clear plans at the moment for greater executive power over the commissioning of London health services, etc.
I think it's a frustration that everybody shares with the amount of NHS land that there is that is not being used effectively while there's a housing crisis and all sorts of other...
Presently there is a review of NHS surplus land, and this is where the devolution has helped to do a pan-London process.
I looked to the ceiling there when you said there's a review of land. Yeah. There's always a review of land.
But the London Estates Board is now a vehicle which can hopefully drive that process quicker than it has been before and give us opportunities to build homes for Londoners.
Is it fair to say that there's a mention in the devolution settlement about subsidiarity, and that actually a lot of the roles that might be devolved, won't stop at the Mayor; they'll go straight down to the boroughs.
Yes,
and we've seen that with the trials to date.
Yeah. And I think when we spoke to the CCGs, to the local authorities, what they wanted was devolution to occur, but really on the condition that integration really around social care should be very much at borough-based level, and that they wanted the natural unit of integration around services to be the borough, not a footprint higher than that, be it an STP area or London-wide. Some things are wise to be done London first and London once only around workforce, but for integration and prevention things, perhaps the borough is a natural geographical footprint.
So do you think Londoners can expect to see quite a change in healthcare as a result of the devolution deal? Do you think they're going to notice?
I think they will over time, but I wouldn't expect to see massive changes in the first 12 months as we go into our initial period. And I think that the change they'll see over time will be more around areas regarding workforce. How do we use the Health Education England Transformation Fund to get Londoners working in health and social care? It'll be hopefully around homes for Londoners. How do we get spare NHS land to be used to build homes for Londoners? I think they're the areas you'll see a difference. You've already indicated to me that you perceive these things take quite a long time, so I don't want to promise to you that it will be occurring in 12 months.
Yeah, no, I get it. I think it's going to be a long time coming, but
it's the right direction of travel.
Yeah, we've got to see what's happened as a result of the Manchester pilot and Barking and Dagenham pilot.
Yeah,
give it time before we. Yeah, I get that. What kind of capacity does the mayor have for influencing the boroughs in the way they're carrying out their duties? As the chair is, alluded to, we've had concerns over smoking cessation. Obviously, boroughs have autonomy and they can decide themselves what the priorities are. Do you see a situation where the mayor will take a more directive approach in the final Health Inequalities Strategy to start requiring boroughs to do certain things?
Do you want me to answer? I don't think he will direct boroughs, but I think what we are trying to create is an offer through this strategy, and indeed through the work that wraps around it, where boroughs are actually offering to come forward and play their role, as we know they are. So, for instance, on excess child weight, when we ran the Great Weight Debate, pretty well all the boroughs engaged with it, and we reached over 2 million people. I mean, that was phenomenally helpful because it gave us a sense of what people in London wanted. And we've taken that work forward and will continue to through the strategy for the most disadvantaged, which will be very specific communities actually, and high streets, but also through other work that will be going on through our various agencies, to identify what it is the mayor uniquely brings to this and what others it is appropriate for others to consider as their role. And partnership boards, because London, the sheer scale of London is not like anything I've seen other than New York in this part of the world. And they don't have this kind of partnership, with the local areas. So the reality checks on what can and can't be done and what people would notice is not necessarily as sharp in New York as here. So our partnership with local government is really important because that's where people will notice a change. It's important that the mayor's persuasive powers and what he can do, and therefore asking what others can do to complement that, make up the full pathway. And that's the way, and I'm sort of in the middle of it, liaising particularly with directors of public health, a very good director of public health in Harrow, in Barking, excellent people who we work very collaboratively with. And I meet them regularly so that I understand what is going on in their areas, but also I ask for their advice. So we don't tell people, we ask advice, and they want to play in, and they do want to help. So the important thing there isn't whether they'll do it, it's whether it feels focused and whether we're aiming at the same things, because there's so many, many things we could do that, if we all work on a few things, we might get something they'll notice.
I think we all aim for consensus, but occasionally that one thing's going to happen, isn't it, where CCG or borough is saying, this is not a priority for us.
Yes.
And we're not going to do it because we've got this priority that we want to spend that money on. We're not going to have a situation where the mayor's coming in and saying, no, you're going to do it my way.
No, we aren't. But actually, thankfully, we're not really in that situation. Because
I'm not saying that's going to happen all the time. It's going to be rare.
Yes, absolutely. I have never taken the view personally that we need 32 in the city doing everything at the same time and having all the same priorities. We don't. But having said that, actually, the priorities we know what they are across the 33, and they're remarkably similar.
You could understand, for example, the London Borough of Lambeth, for example, wanting to spend more on HIV services and possibly sacrificing one other because of their particular demographic in there. So you can understand why they would want to do that. But as I say, we're not going to have a situation where the mayor says, no, you must do this.
No, but what the Mayor might do is use the leadership in Lambeth to show how others could emulate that.
Thank you very much. Thank you. Thank you, Tim.
Thank you.
Okay, if I could talk to you please about the London Health Board. So I'll ask you both, what do you think that the Mayor's view that the primary role and function of the London Health Board is?
Okay. So if I start, the London Health Board obviously has been going for a number of years, and when Sadiq came into office, he wanted to kind of review and look at all structures. And so when we looked at the London Health Board first, and he looked at it very clearly, so he was told that this is a board which tries to bring together much of the health services and local authorities within London. But in fact, when he looked at it, there was kind of a bit of a glaring gap. So he felt that the acute providers and the mental health providers weren't on this group. It's very much of commissioners, CCG, NHS England, and obviously Yvonne and himself, and local authority leaders. So the first thing he decided to do was to make it, first of all, more representative of what the health system in London is like. And we've now got a representative from the Mental Health Trust called the Cavendish Group, Claire Murdoch, and Daniel Elkerlees, who represents the acute trusts. The London Health Board has got a number of roles. One of its kind of key roles initially was just relating to devolution. We had to have a pan-London group which could oversee the application to the Department of Health and the rest of government to develop the memorandum for devolution, get consensus around what it should be, and get a governance system which will allow it to be implemented thereafter. The London Health Board is also an opportunity to bring together local authority and health to discuss key things which we know determine health outcomes regarding be it mental health, be it dementia, be it childhood obesity. It's also a vehicle for Sadiq to show kind of his leadership of the London system. And as such, when it first started, it was seen as very much a meeting in private. So the first thing that he said, and he asked us to do was to make sure the minutes were published, all the time on the on the GLA website. We're in fact now taking, and this is very much having met Onka a few months ago, to saying, very much clearly, the message you gave to me saying that we need to move towards this being, a more public-facing meeting. So we're taking a paper to our April meeting to discuss options around that. How do we move it along the path to giving a much more public face? Because very clearly, as Sadiq is seen much more as a leader within the health system, that needs to be demonstrated in how he works. So we'll be looking at that in our April meeting, how to say we can move towards how other GLA committees operate in a similar way, and we can try to mimic that as well. So taking it from a time when it was a totally private meeting, with no minutes even being published, we've gone to minutes being published and on the path to how can we increase that transparency even further. So it's got a number of governance roles, but for Sadiq, in his leadership role, it's also a vehicle for offering that.
Can I just very quickly, when can I attend? When can I go and sit in and see what's happening?
I'm not the chair of the meeting, so therefore I would have to test that out. But sure.
Anyone can come in here and look at what we're talking about.
Yeah. So it's not a meeting at present open to the public, right? It's not a meeting open to the public at the moment.
Why not?
Because I think we're going on a process of developing the London Health Board, changing its membership, and I think it's a meeting which is trying to be more public facing. And at the moment, the position we have are having our minutes in the public, and I think we're going to go on a process which allows that. But at the moment, like many, as I understand, like many other committees of the GLA aren't meetings held in public. This is a meeting which is not a public meeting, but whether Andrew would like to come, I'm sure we can arrange it. But I think you're asking another question really is, how can any member of the public attend that meeting?
Can I just take you back a bit? You said that the minutes are published. We watched. I think the last meeting, which was 3 months ago, the meetings, the minutes have only just gone up. Do you think that's acceptable?
I think that it would be much better to get the minutes approved and published as soon as possible afterwards,
and
undoubtedly.
Full minutes.
Yeah, and I think we're going to be moving to make sure that, so one of the options is likely to be that to make sure we get the full minutes published, that we get the agenda published. But I don't want to prejudge a discussion which is going to take part in a board next month.
Okay,
But
if I could get
Susan,
your both...
I accept your point of view is that if you're going to have a meeting on the 1st of December, or whatever it was, you want it to be published quite soon afterwards.
Well, we want transparency. We're told that that's what Sadiq wants. This journey towards being more public, how long is this road, quite frankly? Because if he does want things to be transparent, he's been mayor now for nearly 2 years. To have a discussion after 2 years is a very long journey for transparency. And we in the GLA all agree with transparency. If there's nothing going on that needs to be hidden, which none of us think there is, what on earth is the problem with proper
and I think the comments that
transparency?
you're making today and Onka made to me a few weeks ago, I have made sure that I've taken on board and relayed in my advice, and I would hope when we have a discussion in April, you will see a proposal which increases transparency. So we're
increases. It should be completely transparent. Give us a reason as to why it shouldn't be transparent.
What I want to say to you is that I don't want to prejudge.
Okay,
that's fine.
Hang on. What's your advice to the mayor? Should it be transparent or not?
Yes.
Should it be webcast or not?
I think that's one of the options.
What's
consider.
your advice, please, on this matter?
So,
what would you advise a mayor?
So the advice. The advice that I give to the mayor, is one of looking at lots of options.
So all I'm asking, right, you are the advisor to the mayor.
Yeah.
What is your advice to the mayor? Should it be webcast?
My advice was that we should consider webcasting as one of the options, and therefore that was one of the proposals we will consider.
And the second problem I had when I looked at I did look particularly at the minutes. I don't get any idea of who said what. All I get right is a summary of minutes which have been summarized in a very nice, polite way. Okay. I don't get any richness of the discussion. Who said what, why they said. So I can look at the conflict, of interest, which do occur on their health board, and I need to be addressed. Londoners need that to be transparent. Okay. Londoners need to be convinced that health board is addressing their concerns.
After today's meeting, obviously I'm going to reflect, on the advice that you're giving, because you've been around a long time, you've seen how committees work. And this will be fed back into the process. But what I can't do is commit the mayor to doing something which is his decision to do.
Nobody's asking.
We're not asking you to commit. We're just looking at what your advice is. That's all. I know the mayor will make a decision, but I'd like to know what your advice is.
My advice is always to look at the whole range of options, to consider the pros and cons, and then for the London Health Board to have that discussion in April.
What's your view, Professor?
Well, Deputy, first of all, I welcome your interest, because it's quite hard to get interest at this level in health. So I think we respect that, and we need to hear what you're saying. And I think what I would be doing is making sure we convey the depth of that feeling to the mayor and to his advisors, his other advisors. I can give you a personal view. I mean, why would we not have anything in public and transparent? That is where I would be coming from, because sooner or later people will find out if they really want to anyway. So that is a personal view. I cannot speak for the mayor, but what we can do is convey the depth of your interest and real pressing questions on this.
Yes, thank you. I mean, clearly the board deals with some very important issues. Do you think 4 meetings a year is sufficient?
Well, I've heard this question before. It probably, we could meet every month, but I think some of the scale of the work that's going on doesn't make sense to do more than quarterly. I think the important thing is that the work is taken on in between times and there's action and people see results every quarter. as to what they asked to happen. So I think it is enough, so long as the work is going on in between.
If work's going on, it sometimes needs direction. I mean, we almost go back to my first comments. We are concerned, because every one of us on this committee does care about health, that's why we're on this committee. We are concerned, now we hear it's 1.5 days a week, and I accept you give your time freely, in a free way, which is admirable. But if we want to promote health, the amount that the Mayor seems to keep saying, I mean, he's full of words about it, but the action is 1.5 days from advisors, a board that sits every quarter. Now, I'm sure there's a lot of work going on. I'm sure we'd hear about it if it was a transparent meeting, which 2 years on it still isn't. And I'm sure that direction is needed. Now, clearly, if a lot of work's going on and it's being given direction, who's giving it direction when we've only got 1.5 days a week of your valuable time?
Well, I would say that there would be certain commentators who would say if I was sitting here 5 days a week, I'm pretty inefficient. So we put a huge amount of work through in that time, and we don't just spend it here. So I will recruit others to make sure that others are helping, and we have a whole city endeavour, not least my team in Public Health England do an awful lot of work for the GLA. So it's not like it's only 1 day a week and nothing is going on. There is a lot of endeavour. I understand the point about the political steer on this, but actually, at the level we operate as a statutory advisor, I should be able to take instruction and then come back with products, rather than the Mayor have to direct me every month. It's simply not necessary. If we need the advice of the Mayor, we can get that. If we feel that there's something, and that happens in between times, and we've had some really good work on TB and HIV here, where the Mayor has engaged in between health boards.
Advice or direction?
Oh, well, direction from the Mayor, because the Mayor is in charge.
No,
but if we need advice as to what timing or when things could be done, that is something that his office advises us on. But I'm no doubt about he's in charge. And
the time that the Mayor will spend on health is obviously much greater than the London Health Board meetings. And so next Friday, we have a regular meeting with the head of NHS England, and we will then try to focus on services there. We meet the head of the London Ambulance Service on a regular basis. We will meet people in mental health services, because that's a big focus for Sadiq. So there is many meetings occurring between Sadiq, myself, and colleagues. And so there is that continual work. But I hope we're very effective in the use of our time.
So it does all of that work go back to the London Health Board? Is that where it's all reported back?
Not necessarily. So therefore, the meetings, let's say tomorrow, on next Friday, which I will have with the NHS, it will be looking at how they're working, maybe looking at some of the things they might be doing on health inequalities. And so that if it relates to some of the big strategic work, yes, it will. But for the operational day-to-day, the London Health Board is not a board which looks at the daily operational issues of the NHS.
No, but it is something that we are all very, very passionate is now transparent.
And honestly, we do hear that, and believe me, I was really struck when Onka persuaded me very clearly that improving transparency is good for Sadiq.
It is.
Well, we should be looking at what's good for London.
Yeah, and it's good for London. If it's good for
Sadiq, let's put London first.
Yeah, no, quite right.
I don't think you should feel put upon. We give people a hard time over this, whether or not it's health, the Olympics, the housing, whatever. We give them the same problem, and that is we think we're the most transparent nation on earth, but we've still got a long way to go.
A demonstrator.
Sorry, I beg your pardon.
Just to finish off this, I'm pleased that you're broadening the people that are actually on this board. Are you going to include people from the voluntary sector, or?
Again, that's something we will have to consider, because that's another group which isn't on the London Health Board at the moment, and it's something which we will consider. It's not a no, we will not. It's something we will consider.
Okay, so when are we likely to get the wonderful news that we're going to be better equipped with voluntary sector people, etc., and transparent? When do you...
So I can't give you a timeline on the voluntary sector issue, but I can give you a timeline. So after our April meeting, we will have a discussion at the April London Health Board about how we wish to increase the transparency of the London Health Board, and then after that, we will make sure you're aware of the outcome of that discussion.
Okay, will you put in a request at that meeting from this board that the minutes are full minutes and that they go up very quickly?
Yes,
so at least
I will.
If it's not transparent, that we can't see it, we can at least read about it.
I will.
Thank you. I'll finish that section.
Thank you. I mean, the more I listen to it, the more I realize that you both are the advisors to the mayor, but these policy decisions are made by the mayor himself. Have I got it right?
That is correct. I mean, we're not policy makers. We follow the mayor's manifesto.
So the policy setting, right, for Londoners watching, that the policies are set by the mayor personally, and you both act as advisors to the mayor.
So we will give the mayor advice on an issue, let's say, around mental health.
So will the mayor come up will the mayor come up with the issue with saying, I want advice on X, Y, Z, or do you think, or do you go to the mayor, I think you should be doing X, Y, Z?
Both.
Okay. Because I mean, there is some ambiguity about this. That's what I can't understand, right, myself also, because of what people should be, whom they should be approaching to set policy decisions, right? And that's what I'm trying to get onto.
So it works both ways. So we might raise an issue which Sadiq hasn't asked us to raise, but equally Sadiq will come and say, Tom or Yvonne, I really want to focus on something like children's mental health. Can we talk some, what are the issues? How do we improve things? So he will come with areas that he wants to raise because he thinks they're important for Londoners.
I'm going to come to something called SDPs now, which are very dear to my mind and heart. And I want to, first of all, put on the record to congratulate the Mayor for commissioning the report from the King's Fund and accepting the findings of the King's Fund report. Now that we have this report, and you in your presentation you said you referred us to the 6 assurances that the Mayor wants to look at the SDP process. How can the SDP leaders around the London be assured, right, that these assurances will be fulfilled, right, by the SDP plans? How can we make sure that nothing will happen on the ground unless these are fulfilled?
Okay, so I think it needs to be very clear that obviously Sadiq doesn't make the decisions on how the NHS spends its money or implements its plans. His role is leadership and influence. And as you're aware, the STPs, when they were being developed, there was a degree of controversy about their plans, and what Sadiq wanted was an independent analysis of what's going to happen to them, and hence we approached the King's Fund and Nuffield Trust, because they were a reputable body, saying, can you look at these, because we're getting a host of people saying these are fantastic plans which will save the NHS. Another group which are saying these aren't workable, or they're going to cause a few issues. So the King's Fund's report came through, and it did say that the model of care was the right model of care. Where possible, can you avoid going into hospital? Can you do lots of work to keep patients at home, discharge them early, and admission avoidance? Can you make sure that you invest in social care, general practice, community services? Because only then can you actually do what you're saying you want to do regarding keep people at home. But the King's Fund analysis identified a degree of credibility with the issues regarding bed numbers and finances. And because there are 2 big areas whereby if you look at just a demographic change over the next 5 years of population, admissions, etc., we've probably needed about 1,500 more beds in London. But the SDP changes weren't suggesting that at all. And also the financial pressures weren't properly being addressed by the plans. They didn't think that what they were saying they would do wouldn't solve that £4.1 billion gap. So hence the 6 assurances. So since the meeting, we've had a presentation by the King's Fund at the London Health Board to the NHS leaders, the local authority leaders, and there was an acceptance that the STPs, as in October 2016 when they were developed, perhaps needed to be reviewed, refreshed, needed to change, because they weren't as credible as they would like them to be. Since then, I've met, some of the SDP leaders to say, we're going to be using these 6 assurances, and which are around the 2 main ones, which you spoke about, are about beds and money. But it's also about patient engagement, clinical engagement, health impact assessment, and impact on social care. So therefore we will look at the plans as they come to consultation. So when a part of London says, we're now going to develop our plans to do X, which might be a reconfiguration of services, what we want to do is to use those 6 tests to say, are those those plans appropriate? Do they match some of the assurances that Sadiq would want according to the King's Fund analysis? And then, if clearly they don't, Sadiq will be very clear about that, and in his leadership role will want to say that. Because his job is to make sure services, as they change in London, improve for Londoners. Sadiq won't balk at the idea of service change in itself. One of the things which happened last year was how we managed Section 136 patients who are detained under the Mental Health Act by the police and brought to A&E. The system in London wasn't working very well. He agreed to launch a system which would reduce the number of Section 136 holding centres down from about 20 to a much lower number. He knew that people might find it difficult for the mayor to support a reduction in number of services. But what he was very clear about, that the improvement in the quality of the service, the 24-hour nature of the new service, that patients wouldn't be turfed from A&E to A&E was better. So he said, I'll go behind that. And if there are SDP plans which are proven to improve quality of care for our patients and our Londoners, Sadiq will support that. But if a plan comes forward and he tries to use the 6 assurances and they don't match those 6 assurances, Sadiq will say very clearly that that is the case, and will work with NHS colleagues and local authorities to try can we get any of those concerns addressed.
If the mayor sees the 1SD plan isn't working, well, will he stay openly that it's not working and not going to support it?
So I think it depends what you mean by not working, because it could be that there's a small part of it which might not be functioning. But if there's a significant service change which that SDP area is consulting on, and the service changes are such that they do not meet the 6 assurances, Sadiq will look at that, look at how significant those issues are, and then we'll probably make contact.
Advising him on that process, on that assessment.
So I think we will probably, when it comes through, probably get some independent advice, I would imagine, too, because we want to make sure that the assessment is done, kind of fairly and with a high degree of credibility.
I mean, let me be very upfront, Dr. Coffey. One of the architects of North West London, shaping a healthy future, sits on the health board currently. The architect of the Shaping Healthy Future in North West London, STB plan, sits on the health board. And that's why transparency is very important to Londoners, to know what's happening. Here's a report commissioned by the mayor, looked at the health board, on where the architect of the Shaping Healthy Future sits, right, for North West London SDP, and we don't know what's being said on the health board, and that's the depth of a feeling, right, across Londoners, that the need for transparency, what happens there. And I don't want to mention the name of that person, right, but you know that person is, right. You just mentioned the name already earlier on, but I can understand that there's a lot of concerns about what is happening, okay? And of course we know that, for example, that in North West London, the NHS Innovation Board rejected those plans in North West London, saying that they weren't deliverable. So I want to make sure that we have a proper scrutiny of the process, an independent scrutiny that Londoners can trust, right? That this report is being carried forward in a way which they can rely upon.
And I think your initial comments about being pleased that the mayor did commission this report, and I think you'll hear Sadiq sometimes say, I want to champion and challenge the NHS. And I think this is an opportunity for him to challenge the NHS sometimes, because the NHS is working within a very, very tight financial kind of envelope. It's got to make some tough decisions, but we've got to make sure that decisions, as they're being made, he will, on behalf of Londoners, offer a degree of kind of assessment which he will then share if there is significant concerns with those proposals.
It's very commendable what the Mayor's done, getting the report, but I think we need to see progress on how we can take it forward, right, to meet the aspirations and needs of London. That's the point I'm trying to make, and I think that's very important, that we do it in a very open and transparent way, and progress the work which King's Fund has done.
Thank you.
Sorry.
With three sets of questions directed to both of you. So if you can start off with the Thrive program. And given there's an absence of any evaluation framework, timescales, targets, not only this area, in some other areas of the GLA as well, how would you go about judging the success of this flagship mental health program? And very specifically, given again that there's an absence of any framework of evaluation, is the program reaching out to marginalized groups such as LGBT plus people, deaf and disabled people, those with contact with the criminal justice system?
I'm going to probably start. I'm going to probably ask Yvonne also, to comment on this. Is that so? The Thrive program, as you're aware, isn't a single kind of initiative. It's got a number of kind of areas that it's focusing on, and some of the areas it's focusing on do overlap a degree with the health inequality work on mental health. So. Just as we'll be measuring, the impact for mental health in the health inequalities, that might be one of the ways we look at the impact of the Thrive program. There will be some process measures, which so whereby how many people are doing mental health first aid training, how many young Londoners are getting improved access to services, how many people are approached by the Thrive movement and destigmatisation around mental health. But that's more processed. The real outcome measures, I think, which I think you're looking for is, does it reduce suicide rate in London? Does it improve well-being in London? Right? And so there may be some of the measures which may be captured much more potentially in the health inequality. Yvonne, do you want to just mention about the outcome measures for mental health?
Yeah, so we'll be looking at that. I mean, obviously, one of the easiest measurable ones is suicide prevention and, suicide rates. But there are others, how people feel, a sense of well-being. So we're looking at that at the moment. So there will be population measures. Now, they're not very precise. I mean, suicide is because it's part of the Thrive set of programs. But in terms of how we evaluate Thrive, now Thrive is interesting because it's multi-dimensional. There is evaluation being commissioned on elements of it at the moment. For instance, the specific one, I was just checking the name of it, but it's Revealing Reality is the group who are going to do it, and it's independently commissioned research around how we have worked and spent on discrimination and stigma in mental health. They're tricky areas, and sometimes the methods have to be developed by people who have some form in this, and there's not much form in it. We also, in parts of the digital Thrive, are commissioning a formal evaluation of that as well. And there are numbers behind some of this, and we've evaluated the Workplace Health Charter, which is part of it. I mean, so there's some evaluation, but I agree with you. We need to get on top of the whole thing. Yeah.
I think you did said, to refer to Dr. Coffey, that we need to have some sort of numbers. I mean, I know it's hard to measure things like general well-being and the feel-good factor or whatever. But so I'm glad that you take on board our point, and perhaps you could look into, because both of us come from an output-oriented background, local government in particular. Yeah. But the second part of the question, very specifically, groups such as LGBT plus people, I mean, would you give consideration, if you haven't already, to more concrete, is the help getting out to very specific groups? That's what we're getting at.
So
this, and with what success or failure?
On that particular programme, the Mayor signed the Fast Track Cities programme just before Christmas, and that really was very much about reducing stigma and mental distress, as well as other learning from other cities in the LGBT community. And that will have a programme board which will have very specific programmes that will be measurable and will track stigma, among other things like the instance of new diagnosis in HIV. So that's an area. There are other areas in young children and young people in the obesity task force where we will be looking at the overlap between those issues and mental health, which kind of goes through a lot of problems.
Push this point further. I want to move to the next set of questions. Perhaps as you develop the evaluation framework, you could let the committee know.
Yes, very much so.
And one thing I'm aware is that, and I think one of your reports has highlighted that, is that the level of depression and suicide amongst the LGBT community is higher than the London average. And therefore, if you're going to do a health inequality strategy, you've got to look at areas where health is unequal. This is an area with unequal outcomes, and therefore it has to be an area that Thrive and the health inequality strategy has to focus on, because otherwise we won't be addressing the very health inequalities in suicide that we see.
So my second set of questions relates to specific mayoral health programs, like Healthy Workplace Charter and Healthy Schools in London. So what changes are being planned for these existing programs? And also what activity can we expect to see on health and care from the mayor in the next 6 months?
Sorry, I didn't catch the last question.
Well, the first part we covered.
Okay,
The question is both of you. It's about the existing programs such as the Healthy Workplace Charters, Healthy Schools program. What changes are being planned to these existing programs? And also what activity can we expect to see on health and care from the mayor in the next 6 months?
Okay. So, and again, we'll probably
both of you
answer this together. So the Healthy Workplace Charter, I went to the awards ceremony a few months ago to see the gradual expansion of this programme, and I think that, so the plan is to continue this programme and to expand it, because we feel that this programme not only benefits the workers who take part in it, but the productivity of the companies who are healthy workplace companies. The areas we're going to be really pushing towards is trying to get more health companies as well, like general practice, get involved in the Healthy Workplace Charter. For the Healthy Schools programs, one of the big changes we're going to be making quite soon is kind of expanding it to the under fives. So at the moment, the Healthy Schools is a program whereby you get awards, and so we're looking at developing a program which is kind of already reasonably firmed up, looking at there's 13,000 early year settings in London, and can we have a Healthy Early Years program whereby you get a bronze, silver, gold award, and this focuses on preparing children for school regarding behaviour, mental health, eating, diet, teeth, right? So what we do know is that many of the children's health inequalities start early on. And if we can start having a programme which focuses on health in the early year setting, which early year settings really want to take part in, we think that will make a big change for London. We've already got 6 kind of boroughs who are keen to be the first pilots of it, and those 6 boroughs are all in areas of high deprivation. So we feel this might be a programme which can both address early years health and also address health inequalities. So they're the kind of changes that will be probably occurring over the next few months.
I mean, in terms of the numbers, there's 300,000 workers in London now covered by the Workplace Charter. And we've had very good buy-in from local government and actually from quite a lot of business and Transport for London as well, where perhaps we've had less from the NHS and some of the other big public sector organisations. So we are working through, as Tom says, through our Healthy Ambassadors programme to try and get more buy-in there, and through small and medium employers in the health sector. Where we're going with this as well, just to give a sense of the health and all policies, is we've been working closely with the Deputy Mayor for Economics on the workplace standards and the minimum wage.
The Deputy Mayor for Economics?
For the Economics Mayor, the Deputy Mayor for Economics.
It's probably business and...
the business Deputy Mayor for Business. And the economy, I'm sorry, really to expand out a little, to get sort of mental health thinking and health thinking into the workplace through getting people better deal for what they earn, and also better quality work through management and also the way people are treated. So we just begin to broaden it, because the charter is a piece of paper basically. What we want to try and do is change the culture in the workplace to make this a more enabling place for people to do their best. So we've had good interaction, and that strategy is pressing that hard, and there's good evidence behind that.
So I do commend that, because coming from local government background, like some members here, you get very good initiatives, but if they're not mainstreamed or tied into existing, they just flounder, whether it's equality issues or whatever. Yeah. Before I come to my final question, is there another activity we can expect to see from the Mayor in the next 6 months?
So I think the focus for the Mayor for the next 6 months is probably going to be on the Health Inequalities Strategy. Yep. So it's going to be launched, we would hope, at our June London Health Board meeting. And that obviously will focus on, you know, the key themes and the actions that he would want to take you know, kind of part in over the next few years. So I would imagine that will be, you know, a key focus. We you know, and mental health as ever, I think you will see that the Mayor having a large focus on that. The King's Fund, taking Onka's point previously, is going to do a second report to say, okay, where are we now, 2 years on? And so that will probably be kind of, you know, coming out in the September of this year, to have a further reflection on the STP process, which has moved on to integrated care systems. The NHS loves acronyms, so therefore that will be another focus that the Mayor will want to reflect on as well.
So the final question then, looking into the future, the Mayor's coming up in May, will have completed 2 years of his 4-year term. How time flies. So what are your priorities, or rather his priorities, and you helping him, advising him for the next 2 years, for the remainder of his mayoral term?
Okay. So again, we'll probably kind of answer this kind of together. So I think I've mentioned mental health a lot, so I think you can take it as read that mental health will be a priority. Secondly, I think childhood obesity. I think what you'll see that in his London plan, the idea of trying to restrict new obesogenic food outlets within 400 metres of schools, you know, will be something which, you know, we would hope would address childhood obesity. We're, you know, going to have a childhood obesity kind of work stream which has a strong focus. You know, you will have seen an advert recently to get a new chair of a childhood obesity task force to try to develop some sort of citywide approach to childhood obesity. The idea of health in all policies. So I would hope that, just as we've seen in the transport policy, where it's as much about walking and cycling as about buses and trains, so many of his statutory policies will have a strong health input. And I think, yeah, we would hope that myself and Yvonne will advise Sadiq accordingly to have health weaved into all his work to make the changes that he promises. One area which we haven't talked about today is social prescribing, whereby as a GP, Onka and myself will be aware that many of the things which patients come to you with issues that you just can't sort. The reason of the patient's depression is their loneliness. The reason their arthritis is hurting them, you know, is because of their lack of exercise or they're overweight. You know, the reason that perhaps, you know, they may have an issue with depression is because their relationships outside of their family is poor. And I struggle sometimes to address that. Social prescribing, which is in pockets of London, Tower Hamlets have got a great example. You know, if we can roll that out for London, whereby every area has access, whereby a GP can do a social prescription to the voluntary sector, to Age Concern, to Mind, etc., to the local exercise referral system. And I think Sadiq's been impressed with how that can really transform a community. Also has very effective for the patient, and the evidence around the country shows it reduces reattendances at GPs and A&E departments. So it's one of those things which it can have a win-win-win for the community, for the patient and for the health service. I think you might find Sadiq focusing them out in the next few years.
Okay.
It's interesting because before we met here, we also were going to focus on social prescribing. One of the other meetings, what they were looking at the committee is right.
I mean, it'd be really useful because the reports you cover, I read cover to cover.
Thank you. And of course, one of the risks is that we don't know what borough is providing what, right, and how members of the public and doctors can access it, and then maybe some sort of repertoire.
Yeah.
Sorry.
Chair, just to complement that, I mean, there's a good deal of overlap. I think we will hope to see, I will hope to see an improving trend on child excess weight. I think we'll have a task force that will be high profile and that will really help us to recruit a wider range of interests from business, from the charitable sector, to really help us get under this rather than just talking to ourselves all the time. So, our action will be much more embedded with communities and owned by London as something it wants to be proud of. I think we'll want to see improvements on HIV because these are all manifesto commitments. The Fast Track Cities will help us do that. It's a good task force and it will recruit some resource into London as well. We'll obviously want to make sure that devolution delivers something for people. So we will have, a report on that in the summertime, and I want to see it doing things rather than just talking about it. And I think I'd really like to encourage the idea that we're ambitious for innovation here. So social prescribing is innovative. The digital world is very innovative, and we're doing a lot of piloting work on how digital health can help people to help themselves, but also to keep them away from services which may not meet their needs anymore, actually.
Can I just ask, will you be taking proper evidence for any measures that you propose? For example, on obesity, we were told how the Olympics would result in lots of people having more physical activity, reduce obesity. Of course, it did absolutely nothing in terms of increasing people's activity. All it did do was increase the sales of widescreen TVs and sofas. It didn't change the life of absolutely anyone who saw that. And so I would hope that you don't wheel out those same things about if we have lots of sports on television, then people are suddenly going to want to turn to sport. They don't.
You've got to have evidence-based interventions.
Absolutely, and we will be supporting that.
Yes.
Can I just pick up on something? Were you referring to the early years strategy earlier?
So the new early years, healthy early years system.
Yes, we've discussed this I'm sure we've discussed this in a meeting, and you said it's been reasonably firmed up. We were told it was launching in the spring.
Yeah. So therefore, what I was very wary about making sure I'm not going to, I didn't want to list the 6 boroughs, but I think it's launching in a few weeks' time, and we've got 6 boroughs who are going to start it for London.
Okay. All right. Thank you.
Mr. Desai, any more questions? Okay, great. Thank you very much, Dr. Coffey, Professor Doyle, for coming this morning. It has been quite an interactive discussion, and I think we have had a lively discussion on some topics. But look, thank you very much for addressing some of our questions and making sure that we have a better understanding than what we started off. So thank you very much. And thank you very much for all the advice which you give the Mayor and the good work which you encourage him to do. So thank you for all that. Can I ask the guest, can I thank the guest, obviously, but can I also ask the committee to note the report of the background and discussion and delegate authority to me in consultation with the group lead members to agree any output from the discussion?
Agreed. Can we put something in there with a particular reference to the transparency of London Health?
Agree.
Yeah, so we'll get back to you after the April meeting.
Just as a rider. I don't want to stop it. I don't want to...
I do be very clear about the outputs.
I think we've been quite clear about how we think the health should be, including, in my view, we should be webcast and just like any other committee of the Assembly, right? That's what we want, right? Nothing more and nothing less. And also, can we agree the following, please, that that the topics discovered for the 2017-18 Assembly year. Another topic is covered for 2017-18, and also delegate authority to me, a chair, in consultation with the deputy chairman, to agree the committee's priority for 2018-19.
Great.
The terms of reference group the committee's next formal meeting, and if adequate relate to the committee's investigations in 2017-18 Assembly year, and arrangements for any site visits, informal meetings, or engagement activities for the committee's next formal meeting.
Great.
Thank you. Can we please note that the next meeting of the committee is scheduled for 28th of June at 10 a.m.
Noted.
Subject to the agreement of the Assembly's committee, Assembly's AGM rather.
Noted.
Great. Thank you.
Thank you very much. Cheers.
Great.
GLA, Committee Room 5, Sound.